It's a pleasure to be here again and in this beautiful building. I've been asked to talk to you for the next 15 minutes or so about the evidence which is behind outcome measures, which kind of underpins them. And I'll do my best to do it justice in the next short while. So you all know, I guess, because you're here, what the value of outcome measures really is. And there's lots of value. We know, for example, that we're able to demonstrate the impact of services in a very kind of objective way. And we can measure the impact not just for those who do really well in a hospice or palliative service, but for the whole population that's seen by the service. We know that capturing outcomes probably changes things for individual patients, and I'm going to talk about that a little bit more, but also that it potentially can change things at the level of the cohort or the population. And there's lots of other benefits: quality improvement, quality assurance, measuring the effectiveness of what services are doing, understanding the value and efficiency, which is increasingly important. And also, if we use outcomes not so much as outcomes but as assessment, we can understand the population that we're seeing in much more detail, the complexity of what they need. And eventually, we may be able to be in a position where we can compare services in an equitable way, and a fair way. So these are the things we think are the reasons why we're trying to push forward outcome measurements in palliative care. But if you're like me, you want to know the hard evidence. You want to know what really underpins this. If we do this work, and over the next 2, 3, 4 years, we really implement outcomes well into a service, does that actually mean the people coming to that service will get a better care? Okay, so we want to really understand, does it actually change things in terms of patient and family care? Not just for individuals, but for the population we serve. And I think that's the right question to ask, and I don't think one should embark on this journey unless one's reasonably convinced that it's going to do some good in that respect. So I think it's fair to really ask the question, do we know whether and how it's going to make a difference? Now, if you look at these things that we think are the value of outcome measures, you will recognise that much of these things don't happen in a year or sometimes even in 2 years. They're things which happen over some substantial amount of time. There is evidence that introducing outcome measures systematically in palliative care does make a difference over several years. And I would urge you, if you're interested in that evidence, go and look at the Palliative Care Outcomes Collaboration Australia website. It's called PCOC, PCOC. And if you go on that website, you will see all of the reports year on year. Now, they've been running that national data collection for nearly 7 years. It's actually been in development for something like 16 years. And they're just, in the last 2 or 3 years, beginning to show really good evidence that you can actually improve palliative care services nationally. Particularly, they've been able to show improvements across many services in pain management. Now, you would think we get that right all the time. We don't get it right for everyone consistently enough. They've also been able to show change in the duration of the unstable phase of illness. And that's really important, because if somebody's only got 3 or 4 months to live, all the additional days that they have got out of an unstable phase are days when they're better and they can do more. So reducing the length of unstable phase nationally is a really big impact for patients with advanced illness. So I'm not going to talk about that long-term evidence, because you can go on the PCOC website and you can see that. I'm going to talk a lot about what I would call sort of more micro-level evidence. That's macro level. What I'm going to talk about is more the micro level. So we a little while ago, we basically felt that there were a lot of patient-reported outcomes being introduced, and there was a lot more work going on to implement them into practice, but there was limited evidence about what that was really doing, and there wasn't a good review in palliative care about whether that made a difference or not. And we really wanted to know that the whole OAT work, the implementation of outcomes work, all the stuff that's going on in different ways, we really wanted to know that was worth putting our backs and our elbows into to really move it forward. So we undertook a review. There wasn't a consensus about the best way to do it. There wasn't a consensus about the best methods of data collection and also how to transfer information once you've got it between patients and professionals and amongst professionals. There wasn't really a lot of evidence to underpin this. So we did this review to understand what were the methods by which one could do this, but most importantly, what were the effects on the processes and outcomes of care. So we did a systematic review of the literature, we did all of the usual approaches to that, and it was an unusual review because we did 2 levels of analysis, okay? And this is to try and help us understand not only does it work, but if it works, what's the mechanism of action? What's actually happening when we use outcome measures that might be changing what's happening for the patients and families? So this is about trying to understand the mechanism of action, because the more we understand that, the better. The more we can do it well and implement them well. So we did a level 1 and a level 2 analysis. Level 1 was just trying to understand what measures are used, what's the method of capturing data, what were the sample sizes in these studies, just to give us an understanding of what had been done, what disease groups and settings, and also something about completion rates if we could, because there's no point using measures if patients can't actually complete them. And then we went on to a level 2 analysis for a subgroup of that, where there was enough data to say, what were the things being measured in those studies, and did it show that outcomes were actually improving care? Also something about feasibility and acceptability and exactly the impact. So that's the bit I'm going to focus on. The rest I can talk about if anyone's got questions, but the impact on the processes and outcomes of care. So if you do this whole process, what's actually happening, and do people get a better deal? So this is the review flowchart. I'm not going to dwell on it long, but just to say there was a lot of thousands of papers screened, and we ended up with 432 full text articles assessed, and against the level 1 criteria we had 184 included, and against the level 2, 17. So that shows you how much evidence there is in palliative care context, okay? Now, we're a year or 2 on, and we probably would start to find a few more. I myself know of about 3 more that have been published since then, and there's probably more if one systematically searched. So what are the results? Okay, so this is the level 1 results. Remember, this was just trying to find out what's being used, how it was being used, and where the evidence was. And this is only telling you where studies are being done, okay? So the size of the text reflects the numbers of studies. So you can see the populations are largely cancer, but there was a few with other advanced illness. They were mainly outpatients because it's easier to do these studies with outpatients, and they were mainly oncology. There was a few in specialist palliative care, but not many. And then there was a couple in primary care, really important. But there's lots that is not in that we would really like to know more about. The measures are all listed down the middle there, and the EORTC QLQ C30, snappily named, was the one that was the most predominant, but there was lots of others. They were largely patient completed. Occasionally they were proxy completed or completed with help. But most of them were patient completed, and electronic data capture was a big part of this story, but there was some paper, some telephone, and some interview capture. We also wanted to understand what's done with the information, because it's a big part of the story and it's the part that gets neglected. You know, people can capture them if they work hard at it, but then you've got to do something with it. So we looked at who received information, and it was usually about doctors and nurses having that information communicated, and then there was some different things, symptom alerts, summary reports, sometimes printed reports, and that was how people were using it, largely at individual level. The only information we could find out about using bigger cohort data was really from the Peacock work. So, level 2, the bit you're really interested in, actually does this change the processes and outcomes of care for people? So does it mean we're doing a better job for them? So, the effects on processes largely centre around communication. Evidence is largely centred around communication, symptom identification, and then are there more appropriate referrals and actions as a result? So those were the things that were being looked at in this evidence. And outcomes, most of the focus was on health-related quality of life. Some of it was on mental health and distress, and there was relatively little on symptom burden. Now that's really important, because health-related quality of life, you and I know, is influenced by lots of things. So if there is an effect of outcomes, you might struggle to see a big effect size on health-related quality of life. It might be small, because other things, other circumstances, you know, people's kind of social networks and other wider issues may affect their health-related quality of life. So that's an important thing to think about when one's interpreting the evidence there is. So, processes of care. Remember I was talking about symptom identification as one of them. This is the evidence, and I've actually given you the studies. You can go and look at the whole review if you're interested. But basically, it seems that using PCOMs, patient-centred outcome measures, which includes both patient-reported and proxy-reported, but centred on the patient's priorities, so they improve the time with which symptoms are picked up. They reduce the time. There seems to be more discussion of symptoms. And bear in mind, particularly, this is in oncology settings, so that, you know, less focus on all the disease management issues and more focus on the symptoms, and also that symptoms alerts were feasible. Okay, the strength of evidence was sort of intermediate here, but I think one could conclude that probably PCOM's feedback does allow for more efficient identification of symptoms and a broader identification of them. Again, looking at the processes of care, this is about professional communication. Communication between patients and professionals. And you can see that there was more discussion of health-related quality of life, particularly one of the studies that highlighted emotional issues that impacted on that. But there was also much more congruence between what the patient said their health-related quality of life was like and what the professionals understood that to be. So that evidence was a bit stronger, looking at the quality of the studies. So it facilitates some discussion around those issues and increases the patient's understanding of what's going on in an efficient way. Another area was actually looking at the changes in the services provided, and there's evidence here which shows that in general there are increased actions and referrals. Some studies tried to look at the appropriateness of those, but it's quite a hard thing to measure. But in general, they seem to be going up, so people take more actions to get things done. Now, again, bear in mind this is in oncology settings. I don't know how transferable that really is to palliative care settings. It might be that we're doing things anyway. It might not be, and we do more after PCOMs are used. What about outcomes? Because that's the real bottom line. Processes might change, but actually we really want to know whether people are getting improved health status, so their symptoms are better and their quality of life is better and so forth. So looking at overall quality of life, it's a bit of a mixed bag, and actually we concluded that there wasn't really evidence of an improvement in health-related quality of life after the use of PCOMs. Although it's mixed, because some had positive, some were more neutral, and there was one study which had a negative effect. So I really don't know about this one, and I think it's partly because health-related quality of life is quite a broad concept, and the way people measured and understood it in these studies was quite variable. Symptom burden, you'd hope that symptom burden would lessen with the use of PCOMs, but bear in mind there was relatively little evidence on this. So there was some indication in a couple of studies that there was a positive impact, but a couple of studies were neutral, didn't show evidence of a change. A little bit ambivalent in the other one. So it's difficult to say that there's an impact on symptom burden. Now, don't forget that no evidence doesn't mean it's not there. It's just that I think this really hadn't been studied very well. Go back to the original study where symptom burden was quite small. It hadn't been studied in many of the work. What about mental health and distress, sort of mental well-being and distress? Well, actually, the evidence for this was more positive. There's possibly an effect on carer distress, but that was, I would say, weak evidence. But there was better evidence that mental well-being and reduction in distress for patients was present. And there's something there about the confidence people have that issues are going to be addressed. And, you know, that's been evident in some of the qualitative work. So if you can conclude from all this, probably PCOMs allow for more efficient identification of symptom needs. Probably there's more discussion of symptoms and quality of life issues and a better shared understanding of what's going on for the patient in that respect. Probably it empowers professionals to then act and do things which are appropriate. There may be some benefits in terms of emotional and psychological health-related quality of life, but we didn't find evidence of physical or overall health-related quality of life or symptom burden. Again, we need to do that work. It really needs to be done to understand this. So that's the evidence for palliative care, and I'm just going to take you now into a little bit more evidence for oncology, because there's a couple of systematic reviews that have been done to look at routine clinical collection of PROMs in oncology. And I think that evidence is relevant to us because the evidence I was telling you about in palliative care is mostly discrete studies rather than routinely clinically collecting this information, which we're all trying to do. So the oncology evidence is really important, but we need to do that evidence in palliative care and we don't have it yet. So there's a couple of systematic reviews. This one, which asked about whether the inclusion of a PROM in routine clinical practice in oncology was really going to associate with an improvement in patient outcomes, processes of care and health service outcomes. They included 26 articles. Problem is that they rarely used health service outcomes as endpoints, which is unhelpful because actually we really want to know if it's changing patterns of health service use. But there is evidence that there's increased frequency of discussion of patient outcomes in the consultations, just like we saw in palliative care. Some evidence of improved symptom control, some evidence of increased supportive care measures and better patient satisfaction. Okay? But they also recognised that there was a lot required to make this happen in practice. Okay? And they really concluded we need to do more research on this, and they're ahead of us in the research they're doing in oncology. There's another, even later study, a couple of years ago, which really, again, was looking at routine use of these measures in practice. And they felt that PROMs were very acceptable to patients. They enabled earlier detection of symptoms, which reflects back to the palliative care evidence, and probably improved communication between patients and clinicians. But again, they concluded that we still needed more evidence. Some evidence in sort of fairly robust RCTs looking at patient satisfaction, which show a trend to positive effect, but they're not statistically significant. They didn't both achieve sample size. And then there's 16 further studies of less robust design which do report a positive effect. So I think, you know, all of the evidence is suggesting that this is taking us in the right direction, but we need research alongside the implementation work to really give us details about the answers, the mechanism of action, and where to focus the best implementation work. There's a little bit more evidence here on symptom management and how that changes. The debilitating physical symptoms seem to change when people at their first visit had the PROM put in the notes for the clinician to review. So when you reviewed them at the second time, those physical symptoms were better addressed. Odds ratio 2.8, so it's quite high. So, how can we conclude? I think there is some evidence in palliative care, but it's pretty limited so far. But it suggests, cautiously, that probably using PCOMs leads to more efficient identification of symptoms and more congruence between patient and professional understanding of health-related quality of life and symptom issues. And maybe people then act more, but bear in mind that's an oncology setting predominantly. Possibly patients have better emotional and psychological well-being, but again that evidence is only just glimpse above the surface of the water. In oncology, in routine clinical practice, it does seem to increase discussion of the important patient outcomes, but probably might lead to improved symptom control. So, and improved patient satisfaction and more action about symptoms, especially physical symptoms. So I think what we're seeing is glimpses of some of the more micro level evidence that can convince your teams back home why this is important to do. But we don't yet have the more macro level evidence that probably is coming from the PCOP collaboration in Australia, and we need to really do that evidence and build that evidence in this country. Thank you.